Good afternoon, everyone. I'm Wendy Tsai, and on behalf of the AI team, it's really a pleasure to welcome everyone to Audacious Inquiry's webinar, Preparing for the Health IT Implications of Macra. We're pleased that you could be with us for the hour. This session will be recorded, and participants are muted on the call. We'll be taking written questions through the WebEx, through that Q&A button, and also on Twitter using the hashtag AskAINQ. If you have any hiccups, you're also free to email us your questions using media@ainc.com. So today our program will provide an overview of macro regulations and outline the health IT to support the transition from fee-to-service to population-based APMs and to succeed in MIPS. We took into account the audience for today's event and built in some great takeaways for the challenges and questions that you, as part of health systems, ambulatory provider teams, and health information organizations, or HIOs, that you may have in learning about Macra and all of its complexities. Our speakers today are Genevieve Morris, a Senior Director at AI, and Corey Mertz, AI Senior Manager. Genevieve is a subject matter expert and consultant in health information exchange, meaningful use, and health IT policy and program management. She consults to a broad range of public and private sector organizations. She's worked on the Office of the National Coordinator for Health IT, or ONC, Population Health Initiatives, and the ONC Nationwide Interoperability Roadmap and Strategic Plan. Genevieve has developed reports for federal and state healthcare agencies, covering topics such as HIO consumer engagement, provider directories, master patient index, and patient matching methodologies. Most recently, she was part of the ONC annual meeting that took place in DC, actually for a standing room only speaker panel and in the breakout sessions, where she discussed health IT frameworks and APMs. Corey Mertz is a subject matter expert in state and federal health policy and interoperability. He's led work for ONC on strategies to measure the adoption and use of standards and supported health systems in meeting meaningful use. Prior to AI, Corey was part of the ONC team and helped launch and execute the HITECH Act. He was deeply involved in the state health information exchange programs and their implementation. Corey has terrific versatility and expertise in both healthcare policy and technology, and insights when it comes to HIO and enterprise health IT and various touch points on care transitions, workflows, and quality initiatives. So we're excited to hear from both of them today as they share their perspectives and leadership. And now on to the program. Please take it away, Corey.
Great, thank you, Wendy. So, great. So we're going to run through the Macra Rule and provide an overview and then talk through the key considerations. So CMS, loving acronyms and loving to rename things, has done some renaming as a part of this. So they call what they produced in the Macra Rule the Quality Payment Program. So if you hear that, they are talking about the Macra Rules. So what that legislation from Congress did was repeal the SGR formula and establish two new programs and two new paths for providers' payments moving forward. There's the merit-based incentive payment system, and then the advanced APM incentive program. So we're going to talk through both these programs today and talk through the proposed rule. So, MIPS. MIPS replaces three existing programs and really folds a lot of those elements into it. So it replaces the PQRS program, the Value-Based Payment Modifier program, and the Medicare EHR incentive program for eligible professionals only. And that's an important thing to keep in mind, and we'll talk through that in a little more detail later. So the payment adjustments for these programs are going to sunset starting in 2017. So that means the last year of payment adjustments under these programs will be 2018. And that really aligns with the start date that CMS has proposed for Macra, which is in 2017, impacting payments in 2019. So we'll talk through all that in a little more detail. But that's a little background on where MIPS has come from and some of the component parts that make it up today. So who is included in the Macra definition? So Again, this is another point where they changed terminologies. For Macra, they're talking about eligible clinicians, whereas in some of the other programs, they had different terminologies. For instance, eligible professional under the Meaningful Use program. So in 2017 and 2018, the box on the left shows the providers that are going to be a part of quality payment program. In 2019, the Secretary has the authority to expand the list of providers who are eligible to participate in the program. CMS didn't signal what they're going to do there, but we certainly anticipate they will likely add a number of these providers moving forward. An important thing to keep in mind, particularly for those who have focused on meaningful use in the past, other than, the nurse practitioners, physician's assistants, clinical nurse specialists, and certified registered nurse anesthesiologists are new provider types compared to those who participated in the Medicare EHR incentive program. Nurse practitioners were a part of the Medicaid program, but again, now they're going to fall under MIPS, and so it's just an important consideration to keep in mind moving forward. So who's going to be excluded from this program? CMS outlined 3 exclusions in the rulemaking. The first is a low volume threshold. So providers who bill less than 10,000 in Medicare claims in a year and see less than 100 Medicare beneficiaries in a year, they would be excluded from having to participate in either MIPS or the APM program. Also for ECs who are in their first year of participating in Medicare, and then certain providers who reach certain thresholds of participation in advanced APMs would also be excluded from MIPS. And one important thing to keep in mind here, that first low volume threshold, if you do group reporting, it's based on the full group. So if you have 5 providers participating in a group and you're going to report under MIPS, all of their billing volume would add together and all their patients that they've seen would add together. So if it went over 100 or 10,000, they would be included in the program. So this slide is really trying to provide an overview of how payments are going to be modified moving forward under this program. So for 2016 through 2019, there's going to be a 0.5% increase in the fee schedule every year for all providers. After that, there's going to be no change up till 2026 just for participating. So MIPS is going to kick in, the payment adjustments are going to kick in 2019, and that's going to be based on your performance in 2017. So this is, again, very similar to how they've approached things in meaningful use in some of the other programs, that it's a 2-year look-back period to determine what your payment adjustments are. So in MIPS, it's going to be escalating from a plus or minus 4% payment adjustment that you could receive in 2019 up to a plus or minus 9% starting in 2022 and moving forward. So there's definitely a significant amount of funds kind of on the line here, and going to be important to keep in mind. In the advanced APM program, providers who qualify for that can receive a 5% bonus in their payments. And then the other thing to keep in mind on this slide is in 2026, providers who are qualified participants will get a 0.75% increase in their fee schedule moving forward, whereas all other providers will only receive a 0.25% increase. So, some added incentives to be a QP in the out years once the 5% bonus ends. So, as I kind of alluded to earlier, there are 2 options for eligible clinicians in this program as far as reporting. They can either report individually, so the providers go forward, put their individual scores forward, or they can do group reporting. So in this program, CMS is proposing to define a group as a single TIN with 2 or more ECs who have reassigned their billing rights to that TIN. So this is just an important thing to keep in mind. Groups are based on the TIN NPI combos. So as you consider how you want to structure your groups, it's going to be important to look at your existing way you have your TIN structured. And this is also going to be helpful for providers who join your organization over the course of the year. If you do group reporting, it could help even out some of those numbers. And the other thing that CMS, the legislation requires CMS to provide a virtual group option. So multiple providers who aren't necessarily in the same geographic area potentially could work together in a virtual group. In this NPRM, CMS did not provide an option for that, but they plan to in the future. So how do you get scored in this program? So CMS has created a composite score across these 4 performance categories that they've established for the MIPS program. So there's the quality category, there's a resource use category, there's advancing care information, which is how they have renamed meaningful use. So keep that in mind anytime we're talking about advancing care information, or ACI, that is the former meaningful use program. And then the 4th bucket is Cpia, which is clinical practice improvement activities. This is really kind of the net new activity in this program. The other 3 are really based on those programs we talked about before, but Cpia is really a kind of new set of activities that CMS has outlined in this rule, and we'll talk through that in a little more detail in a few slides. So in 2017, quality is going to be 50% of provider score. And one of the important things to keep in mind here for both the quality and resource use category is that provider scoring is going to be benchmarked against the performance of providers across the country. So you'll get a 1 to 10 points for each quality measure that you report, but that's going to be based on comparing how you did compared to all the other providers who submitted that quality measure. So it's going to be a little hard at the beginning to tell how you're doing compared to other providers, and it's also just a very different way to think about quality measures. For instance, under the meaningful use program, the score you got didn't impact your payment. It was all about just reporting the quality measure. So how you performed didn't matter at that point for the meaningful use program, but that is going to be a very important factor in MIPS moving forward. So again, resource use, you're also going to have that similar benchmarking against other providers across the country. Advancing care information, we'll talk through this further down in the slides, but there's kind of a 3-pronged approach to scoring here. That's going to be worth 25% of your score, and Cpia is 15%. And we'll talk through all the details moving forward. So for the quality performance category, most providers are going to have to submit 6 quality measures, and there's a litany they can choose from in the rule. And then CMS will also calculate 3 claims-based population measures for providers as well. So for those claims-based, you won't have to submit information, but you will have to submit information for those 6. And again, for each of the quality measures, you'll be scored on a 1 to 10 points that will be based on comparing your performance to other providers across the country. And CMS has tried to address some of the concerns they've heard from stakeholders over the years about the lack of quality measures that are applicable to specific specialties and subspecialties. So they've created specific listings of here are the quality measures that we think are applicable to these folks. Sometimes it's less than 6 quality measures, and so then that's as many as they have to report. And again, this is all proposed, and the proposed quality measures are in the rules, so you can take a look at them in there. So the resource use category, again, CMS is going to calculate this for you, so you're not going to have to submit any information here. It's going to be based on your Medicare Part A and Part B claims, and it's going to be attributed at the 10 NPI level. So for advancing care information, there's definitely some significant changes with how the meaningful use program works. So when you think about meaningful use, you think about you had specific thresholds that you had to meet, and if you hit that threshold, you got your gold star. You had to hit that threshold for all the measures, and then you got a gold star. Now it's a much different approach. They've broken the scoring up into 3 buckets here. So there's first is the base score. So you have to, get a yes on every measure. So you have to do every measure at least 1 time to get the base score. And then there's a performance score, which is based on how you perform in each category. So for instance, with the health information exchange measures on this slide, so say you got a 80% for your transitions of care. That is going to give you 8 points towards the performance score. And for the performance score, you can get up to 80%, and it's based on your performance in these individual measures. So you take your percentage, times it by 10, and that gives you your points. Then you add them up for all those, and you can get up to 80 points in that category. And you'll add that to your base score, and that'll give you your overall score for this category. You can also get 1 bonus point if you do an additional public health reporting measure. You're required to do the immunization reporting, and then you have the option to report others. Another really important thing to keep in mind with the advancing care information category now is they've gotten rid of all of the exclusions that were previously a part of meaningful use, except for the exclusion for immunization reporting. So this is going to be really important to keep in mind, particularly around the transition of care and e-prescribing measure, where a number of providers historically were under that 100 threshold. So it didn't necessarily, they didn't worry about those measures. Whereas today, if you don't send at least 1 transition of care electronically and do at least 1 e-prescription, you are going to fail the base score, and you will not be able to get a score for the ACI category at all. That's the way they've structured it in the MPRM, is that if you fail any of those measures in the base score, you get no score overall. So for 2017, CMS is providing two options. This is the primary measure proposal. This is really based on the stage 3 measures that they've outlined previously. They also have a proposal, again, for 2017 only, to use the modified stage 2 measures and thresholds. So there's some different measures here. Some of the health information exchange measures that are in stage 3 aren't in this, for instance, around receiving information, and the more complicated reconciliation measure is not part of the 2017 measures. The other thing to keep in mind for 2017 is you'll have the option to use 2014 or 2015 edition CERT in MIPS as well, and you can use different combinations of that CERT as well. One other thing, just interesting thing to note here, in the rule, it's a little unclear if CMS is allowing a performance score if you use the 2017 measures. We asked, in our comment letter to CMS, we asked for clarification on that, but we assume if they are going to do that, they would do it similar to the other proposal and would allow all of the measures to be a part of the performance score other than e-prescribing, to model it after what they proposed for the other categories. So we'll have to see what they say on that. We certainly think that's where they're going to go, but it was an unclear point in the rule, we felt like. So again, I just want to hit on the point I made earlier in my remarks, is that this really only changed the Meaningful Use Program for Medicare eligible professionals. The Medicaid program is still the same. Eligible professionals who are participating in that program still have to meet those thresholds. They're going to have to submit information to two separate programs. They're going to have to submit it through the MIPS attestation methodology. You're still going to have to go and submit your information through the Medicaid attestation portal as well. That was another thing we commented on and requested that CMS provide a unified method for providers, because that's certainly going to get a little complicated for them to be reporting in two places. The other thing just to note here, CMS did release an NPRM 2 weeks ago, making some changes to the Meaningful Use Program, reducing some of the thresholds for hospitals for the Medicare program, and also providing a 90-day reporting period for 2016 for all Meaningful Use providers. So moving on to the fourth performance category is the Cpia. So again, this is that net new category, and it's really focused on they provide a lot of options. So there's over 90 activities that CMS included in the rule, and so these activities are things like providing expanded hours for your primary care clinic, integrating behavioral health and primary care information. There are ones specifically focused on participating in health information exchange. So there's a wide set of activities that providers can participate in, and CMS weighted them either high or medium difficulty. So high are worth 20 points, medium are worth 10 points. And you need a total of 60 points in this category to get a full score. And this category is worth 15% of your total score. And there's some lower thresholds for certain types of providers in rural areas and non-patient-facing providers. And you have to do this activity for up to 90 days during the performance period, whereas all the other categories are based on the full year reporting period. One important thing to caveat to note there is CMS has, in some of their comments, through congressional testimony and hearings, expressed a willingness to, create a shorter performance period in 2017 and move around the start date in 2017. So it'll be interesting to see what they propose there. But it definitely seems like they've heard stakeholders' concerns that there isn't enough time to prepare for 2017 if it is a full reporting year. So, as I mentioned, you have to submit information for 3 of the 4 categories. So for resource use, that's based on claims data. CMS is going to calculate that for you. For the other 3 categories, you are going to have to submit information to CMS showing how you performed. So CMS provided a number of options that you could take in the rulemaking. You could submit information through qualified clinical data registries, qualified registries, health IT vendors, you do attestation, use claims data, and you could use the CMS web interface. An important thing to keep in mind with this is CMS generally talks about you can only use one method for each category. So in the quality reporting, the quality performance category, you're generally allowed only one reporting methodology. So you'd have to pick one from that set in the Senate category, but you're able to pick different reporting methods for the different categories. So, I could do the QCDR for quality. I could use my health IT vendor for the ACI category. CMS is a little unclear in a couple of places where they seem to say you could use multiple methods for a single category. That's another point where we ask for clarification. But most of the rule, they seem to imply that you're going to have to do one and only one method for each category. So with that, I'm going to turn it over to Genevieve to talk through the advanced payment model.
Great, thanks, Corey. Appreciate it. And as Corey mentioned earlier, whole new set of acronyms that we're dealing with. So I will do my best not to use the acronyms, but will admit that we've already fallen into using all of the new ones already. So advanced APM. So going into the rule, everyone knew that the APM track existed. But there's so many different things that can be an APM, including what the commercial folks are doing. And so CMS actually decided to slightly rephrase the terminology in the rule and refer to the official APMs that can meet the program requirements as advanced APMs. So there are lots of APMs, but not all APMs are advanced APMs. So in order to be considered an advanced APM, the alternative payment model, whether it be an ACO or a bundled payment or a patient-centered medical home model, any of those models have to meet these criteria in order to be considered an advanced alternative payment model. So number one on the list, and I think this indicates how seriously CMS is taking the use of health IT, frankly, is that the APM has to require participants to use certified EHR technology. So that means that they're using technology certified to either 2014 or 2015 editions for a specific set of criteria. And there's a threshold around the percentage of providers who have to use it. They are suggesting 50% in the first few years, and then a movement towards 75% as we move through the program. Second point there is the APM has to provide for payment for covered professional services based on quality measures. So long-winded way of saying that the payments that they're making have to be tied to quality measures that are very similar to those in the MIPS program. So as Corey mentioned, in the quality category, there are hundreds of CQMs that you could choose from to report, and whatever you end up using in your APM has to at least be comparable to those, so they don't have to be exactly the same. And then the third bullet there is that there must be downside risk. So any APMs that are not taking on downside risk for the providers involved do not count as an advanced APM, and that's an incredibly important point for folks to be reminded of. And I apologize, our slide just went to sleep. So one other thing to keep in mind is that Medicare Advantage is not considered Medicare for purposes of advanced APMs, and one of the main requirements is that you have to be contracted with CMS in an APM for it to be an advanced APM. So simply contracting with a Medicare Advantage plan to have an APM or a commercial payer, at least in the initial years, does not get you to that status. And then CMS is going to release every year who counts as an APM. This slide is just sort of an overview of the nominal risk standards. So when we're talking about downside risk, CMS has proposed specific measurements around what would be considered nominal risk. And as you see there, it's marginal risk of at least 30%. Really technical, but the baseline to think about there is that if you're not taking on enough risk in your APM, you won't end up being an advanced APM. For purposes of 2017, CMS has announced these models as APMs that can qualify as advanced APMs. So if you are an eligible clinician and you are in a shared savings track program track 2 and 3, Next Gen ACO, the Comprehensive ESRD Care Model, the new program, which is the Comprehensive Primary Care Plus that's getting announced in just a few weeks, or the Oncology Care Model, which is a bundled payment, you can participate potentially in the in the APM track of the program. One note on the shared savings, track 1 is not an eligible advanced APM because you are not taking on downside risk. And so if you're moving into tracks 2 or 3 from track 1, then you can participate. If not, MIPS is your option. So this slide talks a little bit about being a qualified APM participant, so QP. So we have the term EC, which is your eligible clinicians, and the term QP, qualifying participant. In order to be a QP, and that references the provider themselves, First, they have to be in a model that is considered an advanced APM. So that list that I just showed you on the previous slide, whatever APM they're in has to be from that list. Then they have to be in an advanced APM entity. So that means that you're actually in a contractual relationship with other organizations, with a health system or with other providers, and that's considered the APM entity. And then the individual themselves is the qualified participant. One really important note is that in order to be considered a QP, each year a certain percentage of your Medicare beneficiaries or the claims that you bill for have to be paid for under the APM that you're involved in. In other words, you could be in an advanced APM model, but if enough of your Medicare beneficiaries aren't actually being paid for under that model, you don't actually qualify as a QP. So it's not an automatic thing if you're in one of those models. Each year you have to meet the qualifying requirements. If you do meet the QP requirements, you get to be excluded from MIPS, so you don't have to do the ACI reporting. You're already doing quality measures for your APM, so that sort of carries over from there. As Corey mentioned earlier, you get the 5% lump sum bonus for a few of the years, and then in 2026 you get a higher payment rate. I think the thing to emphasize here is that just because you're in an APM does not necessarily mean that you are a QP, particularly in 2017. The performance and payment timeline, really similar to how it works for the MIPS side. So 2017 is your first performance year, and then 2018 is where your incentive payment is based. So financially, how you perform in 2018 is how they're going to calculate your bonus for 2019. How you perform from a perspective of your quality measures and everything else is based on 2017. Slightly confusing, we understand, but it is currently the way that it is set up, and they might change that in the final rule. We're not really sure. And then other advanced APMs. So starting in 2019, for the 2021 payment year, so 2019 performance year, other payer advanced APMs that meet certain qualifying criteria can actually apply and help an EC become a QP. One important note here is that you still have to be contracted with CMS for an APM. So you can't just work with the commercial payers or Medicare Advantage and qualify as an other payer advanced APM. You still have to be contracted with CMS first, but then all those other payer APMs that you're in can help boost your percentage thresholds of how many of your Medicare beneficiaries are in an APM, and then that then helps you qualify for a QP. So folks who might not qualify this year because they just don't meet that threshold, in 2019 might be able to qualify for the APM side, and obviously that's what CMS is hoping will happen. And so Medicare Advantage and Medicaid, as well as the commercial APMs, all count towards that other payer APM category. So I want to shift a little bit and talk specifically about the health IT framework that we've built to support alternative payment models. I should note that we developed this under contract to ONC, though this does not necessarily represent the views or opinions of ONC, as it is an AI work product. What we decided to do was take something the HCP LAN created. So the Healthcare Payment Learning and Action Network is a collaboration of payers and government and patients, stakeholders, and transparency advocates who are working together to try and figure out how we get our systems from where we are now in fee-for-service to the alternative payment model realm. And so what they did is they took a concept that CMS originally started when they released their goals around being at 50% in APMs and then 80%. They took these categories that CMS laid out and really laid out where do the different payment models fit into these categories. So category 1 on the left there is your straight fee-for-service. So that's, I'm not doing anything else except the fee-for-service world, lowest bar from a health IT perspective, frankly. Category 2 is your pay-for-performance model, so still all built on the fee-for-service, but it adds in things like P4P, HEDIS reporting, quality measure reporting, all those things that folks have been doing the last few years. Category 3 is where you start to get into your APMs, and so Category 3A is an APM with no downside risk, so that's like a patient-centered medical home where we're not taking on any risk, we're just getting additional payments in order to provide more care. Category 3B and then all of Category 4 indicate that you're taking on downside risk. So 3B would be something like the Comprehensive Primary Care Plus initiative, where you're taking on some downside risk, but you are a medical home. And then category 4 is really your population-based payment models. So 4A is looking at disease-specific payment models, like bundling a payment together for a specific disease group. And then category B is your general population. So for example, here in Maryland, we have the all-payer rate setting system for our hospitals. That would be a category 4B example. So what we did is thought through, your technology needs for each of these categories, or at least categories 3 and 4, are very different than what you need for categories 1 and 2. And so we created something called the Health IT Framework, and I promise you I'm going to break this down in a couple slides because I know that this is a lot to look at. But what we did is overlaid health IT needs across a couple different categories that we built around things like having clinical data available, or care coordination and management services, or quality measurement. And we tried to list out what you needed in order to be able to perform in categories 3 and 4. And so we have the current state at the top, which is what folks are doing now. And as we did interviews and talked to folks, the folks who are in APMs right now and have been for a few years have really increased their health IT use in order to be successful in those models. And so as you move from left to right, the health IT needs get significantly more complex and deeper. And then on the bottom is an ideal state. So if we're trying to move APMs nationwide and have higher and higher numbers of patients covered under APMs and receiving services that way, what are the health IT needs in that case? And so one thing to sort of note about the Health IT Framework is that everything that's in categories 3 and 4 is, of course, backwards compatible to categories 1 and 2. You could use everything in those categories for your fee-for-service models, but the payment incentives really don't align for folks to do that. And so, folks right now seem to be somewhat in both camps with their health IT use. So what I want to do is focus on categories 3 and 4 and focus on the ideal state. So this is not where we are today. This is where we think we need to get to in order to support APMs at a higher scale. And I just want to highlight the categories really quickly and the items we have in them, and then we'll jump into some strategic considerations for some groups. So this first one is clinical data capture at the point of care. The box you see on your right, the organizational EHR with all clinical data interoperable, that is the ideal state for category 3. So when you're not talking about the population-based payment methodology, really you need an EHR where you're easily exchanging clinical data with everyone else that's in your APM, and frankly, everyone outside of it, since your patient probably isn't just going to stay within your APM model to receive care. The second box includes the community-based and social service systems, because that's really focused on category 4. When you start getting into a full population model where you might be capitating payments for your whole population, it is vitally important to pull in community-based and social service systems data in order to manage the care of that patient, because I think we all know that care doesn't just happen at the doctor's office, it happens across a much larger continuum. And so you have to really be able to pull that data in to be successful. The next category is care coordination / management, and I will say I think this is the largest category of items, and that's honestly because if you don't properly manage the care of your patients, you will not end up reducing costs or creating efficiencies within your system, which is the goal of APMs, to provide better care, smarter spending, more efficiently. So it's in the care coordination management. There's a couple things that are category 3, and there's a couple things that are both categories 3 and 4. A closed referral loop, really, really important, and we really don't have this today, sadly. So when providers are sending patients out to other specialists, they need a way to be able to get the data back that the patient actually went for that follow-up visit, and then know what happened in that visit so that they can continue to care for that patient appropriately. That's a really important capability to have that, frankly, in today's world doesn't really exist, particularly in a standardized way. A shared care plan integrated with your EHR and available to the entire clinical care team, patients, and their caregivers. So today's world, care plans are frequently being developed in third-party systems, which is totally fine, but it causes a lot of data reentry. And so folks have to enter data in the EHR, and they have to enter it in the care plan, and then often that care plan's not getting shared with the entire care team or with caregivers and patients. And so really in the Category 3 world, you need to be able to share that care plan with patients and providers, and we need a more automated care plan that can pull the clinical data from the EHR, though it could still obviously be in a third-party system. Event notifications. So there are a lot of event notifications taking place. This is a service that has boomed over the last few years. Actually, really the last 2, I think it's picked up significantly. And event notifications are things like my patient showed up to the hospital and they had an asthma attack and they went to the hospital instead of coming to me, right? But that provider needs to follow up with their patient, and so event notifications are meant to trigger that follow-up. And really, we need to move towards integrating them into the workflow. And that this does not necessarily mean the workflow of providers. Often with things like following up with patients, it's not the physician themselves, it's their care coordinator. And so really being able to integrate into the workflows of care managers and care coordinators is important. Near real-time benefit eligibility information for the patient. Really important when you're trying to send a patient out to another provider as a referral. In order to manage costs within your system, you have to know if that's going to be in plan for the patient or out of plan. And right now, that data really isn't available within the ordering system for most providers. Some info is available for medications, but for referrals in particular, that's really lacking. And when that gets coupled with clinical decision support, so a provider can know whether this is really the right method of treatment for a patient, that becomes a really powerful tool for making smart referral choices, which providers need to be able to do. For categories 3, but really 3B, where you're taking on downside risk, and category 4, a provider value score that would be available during the point of ordering is really important. And we consider a value score to be a combination of cost and quality. So it's not just the quality of care the provider is providing, it's not just the cost, it's really a combination of can they provide high quality care at a reasonable cost. And that value score then helps providers make better referral decisions. It helps them build out their networks, all things you have to be able to do in an APM. And then for category 4, there's 2 items here, the shared care plan that's integrated with any system and available to the entire care team. So again, that's incorporating social services and community-based systems. So you can imagine a care plan that's shared across social services would be hugely beneficial to ensuring that patients have rides when they need to have rides because they have a goal of getting to a certain number of appointments. That would be a very powerful tool. And then event, care gap, change in risk score, patient-generated health data-based notifications, sort of all of these other things that you can notify care teams about, incorporate into the workflow. Again, very powerful tool for helping to manage the care of your patients and be very preventative and proactive instead of reactive, which in an APM, you do not want to be reactive because that probably means you're not going to have a shared savings. You want to be very proactive, and really all of these tools let you do that. Quality measurements, so what we would like to see us move towards is real-time patient-centric ECQMs that's calculated across the entire system or across the APM. Right now, CQMs are frequently very provider-centric. They're not necessarily holistic, and frequently are just calculated one provider at a time. But in order to really manage your APM, you need to be able to pull all that data together for everything the care team is doing for the patient and calculate a really complete ECQM that's based on that patient themselves. And then the real-time nature helps you manage care in real time rather than a year later finding out, oh, I could have changed this in how I practiced, but I didn't know that it was a problem. And so that allows you, again, to be very proactive. And then for category 4, it's the concept of calculating the ECQMs across a step population, because it really is that population-based payment methodology. You need to be able to do that for a set population of patients rather than just an individual patient. Data aggregation and attribution. So a lot of the services that we talked about in the care coordination and in the quality measurement are really based off of the concept that you're going to be able to aggregate together data and correctly attribute it both to the correct provider and the correct patient. And so in the ideal state, for categories 3 and 4, there's a need to aggregate multi-payer adjudicated claims data and multi-organization clinical data. So in other words, there's a need to be able to pull together the administrative data that gives you a lot of idea around the cost of what's happening, what's being spent, as well as just completing out the picture, since claims data isn't, or clinical data isn't always complete when you're pulling it out of the system. So there's a need to pull that data together along with your clinical data and really combine it together for an individual patient, which gives you better insight into what is happening with that patient, which is what the goal of this is. To be able to do that, you need near 100% accurate linking of claims and clinical data from multiple organizations. In other words, not from a single organization, but you have to link this data from multiple sites together. And you need an interoperable provider directory that is both hierarchical and relational. Because there is a need to do things like calculate quality measures not only at the APM level, but also at the provider level, you really need to be able to link together providers to the different contracts that they are providing care under, so that they can see their quality measures in many different ways, so that their risk scoring can be done in many different ways. And so that just becomes an inherent need of being able to do those other services. And then risk scoring. So real-time risk scores from claims and clinical data. So in the ideal state, today's world, most of the time, risk scoring is based off of claims data. The payers have been doing this for years. The managed care organizations in particular have gotten really good at risk scoring, but it's based off of claims data. And really, again, to give a complete picture of the patient, the claims and clinical data together gives you a more accurate risk score. And then if you can have that in closer to real time, again, it allows you to be proactive about your patients and be able to intercede and perhaps prevent an adverse event or prevent a hospital visit. And then for Category 4, you're looking at real-time disease-specific risk scores. So in other words, not just general risk scoring around a lot of different things, but disease-specific risk scores that are tuned specifically for Category 4A. And then for Category 4B, you're really pulling in together socioeconomic data, clinical data, and claims data. Again, when you're managing an entire population, what's happening outside of the care system is really important to keeping your costs down. And so pulling in that socioeconomic data allows you to get that more holistic view of the patient for risk scoring. And then the final item in the ideal state, and this is really a financial management piece, that you need to be able to calculate total cost of care from claims data, clinical data, and services data. So one thing that's really important to keep in mind, under these alternative payment models, providers and their care teams are providing a lot of services that aren't necessarily going to end up on a claim. So CPC Plus, for example, you're being given a set amount of dollars to provide comprehensive care for your patients. And so you're not going to, on a claim, say, well, I did 10 educational classes for this patient. We provided them with 10 different rides to these educational classes, et cetera. So as we think towards the future, we need a way to be able to incorporate that services data in with the clinical and claims data so that you really are getting a total cost of care and understanding whether you're actually saving money across your APM. That becomes really important. That's certainly something that we don't have today, particularly the service data that was emphasized to us multiple times while we were doing our research. So I'm going to hand it back over to Corey. He's going to do some health system and ambulatory provider considerations, and then we'll move into some HIO considerations.
All righty. So we have outlined 4 steps that we think are going to be really important to take in these early, these months before 2017, because you need to start preparing now as you think about the 2017 performance period for health systems and ambulatory providers. So, the first essential step is really figuring out which of your providers are actually ECs. So you should pull your financial data, so look at, take the relevant categories of providers who can be eligible clinicians, pull your financial data, and run it to determine if you have providers who are historically under $10,000 in Medicare claims a year and have under 100 Medicare beneficiaries a year. Now, it's important to keep in mind these low volume thresholds are going to be determined by the 2017 performance data. So, the historic data isn't going to necessarily tell you what's going to happen in 2017, but understanding that in 2016 or 2015 or 2014, that they would have hit that low volume threshold, I think will be valuable information for you to keep in mind. And again, this is an area where CMS also has expressed openness to changing the low volume threshold, potentially increasing from 10,000 to some higher dollar amount and potentially a higher beneficiary number. So that obviously will change it. But if you have the information pulled already and CMS makes a change to whatever that number is, it'd be easy to rerun it and see who falls under the new higher threshold. So again, get that data, map it out, figure out who your eligible clinicians are so you know who you have to worry about. Second step is really going to be to understand how your TIN and NPI combinations are within your organization. So obviously this is going to be a particularly important point for health systems. Like a 10-doc practice, probably not going to have to worry about this, but large health systems that have multiple ambulatory provider groups, multiple specialty groups, multiple primary care groups, it's going to be really important to do this mapping. And this is really going to help you as you think through some of the additional steps, how your organization is structured today and how you might want to think about restructuring it in the future, particularly for the MIPS category. The third step to really take is, and I think what we're hearing and seeing in the marketplace and what CMS is estimating is that the vast majority of providers in 2017 are going to be in the MIPS track of the quality payment program. Most providers are not going to have the patient volume or payment thresholds to become qualified to meet the QP advanced payment side of the rule. So pretty much everybody's going to be in MIPS in these early years, but I think it's still really important to understand within your organization what advanced APMs your providers are participating in, what those thresholds look like on both the patient and the payment side, to understand how close you are today, and if this might be a viable option in future years if it isn't in 2017. Because again, those providers will not have to participate in MIPS. So just really important to understand that. So the last step is really to pull a lot of this information together. Again, so you'll know, all right, here are my ECs, here's who's potentially going to be in the advanced APM track, so I don't need to worry about them for MIPS. And then I think when you're really thinking about your eligible clinicians in MIPS, that's where you're going to want to take those TIN NPI combinations and see what those look like today. Because for a lot of these categories, it's going to be really important if you're taking a group reporting option that you have like providers groups together. So thinking about this, for instance, with the quality measures, right? You have to submit 6 quality measures. I mean, if you have different specialties grouped together who don't necessarily have overlap in 6 quality measures, you're going to really bring your score down in that category, and it's worth 50% of your score in this first year. So that's really going to hurt your performance overall. Similar as you think about like the ACI category, for instance, you have different providers. Some providers are going to perform better in the e-prescribing area than others. So it's just really thinking about how can you group providers in a way that's going to help you score as high as possible for your CPS score. Because your performance on that, again, is going to be compared against providers across the country and determine your payment adjustments for 2019. So CMS is going to set a performance benchmark. If you meet that or higher than it, you're either going to receive a neutral payment adjustment or some positive payment adjustment. But if you're below it, you're going to be on the negative side and get those negative payment adjustments. So again, really important to group like providers. Think about what quality measures are they going to do and where is the similarity there. I think that's also going to play out in the resource use category as well. Having like providers together is going to be really important for that and really help you do your best. And, I think the other piece with grouping providers is really, and this is kind of the undertone of what I was talking about, really thinking about how do I maximize my performance in MIPS. Because again, most providers are going to be in MIPS in the early years, so you're going to be competing with a lot of other providers, and you want to have the best score you can in this category. So I'll turn it back over to Genevieve to talk through the HIO considerations.
Great. So HIOs. So I'm going to cover 3 things, and then I'm going to try and move quickly so we have some time to answer questions. So we're going to talk about supporting ECs in reporting the quality ACI and Cpia performance categories, some of the APM opportunities, and then a couple other quick considerations. So one way I think HIOs need to consider supporting providers is being a third-party submission method. So CMS under the legislation was required to encourage is a loose word, but encourage / push providers to use the qualified clinical data registries or certified technology to report measures to CMS, and that's across all 4 of the categories. If you think about it, right now, the meaningful use measures don't get reported using either of these methods. Folks go in and they key in their numerators and denominators, and quality measures are kind of a mixed bag. Some folks use the QCDR, some people use their certified technology, some of them actually just still key them in because that's easier. But really they're trying to push for electronic methods of submitting information, and I think Andy Slavitt in his congressional testimony last week commented that they feel like the reporting methods is what are really difficult for the small providers to meet, that the reporting burden is what's high. And so I think CMS is just going to continue to push for electronic methods to try and ease the reporting burden, particularly on smaller practices. And that seems to be how they're thinking about it. And so they did that, they gave bonus points. So if you use a QCDR or your certified technology / a health IT vendor, which CMS did not make clear the distinction in the rule, and we're hoping they clear that up in the final, you get bonus points for those submissions. So again, to Corey's point, you're competing against every other provider in the country or group in the country, and so any little edge you can get may actually be the difference between a neutral score or receiving a reduced payment. And so those bonus points may actually become very important. CMS has not specified that the electronic reporting requirement for file types. We suspect it's going to be what are called the QRDA files. They sort of hinted at that, but didn't really specify for some of the categories, so we're waiting to hear on that. The next category we're going to move into is the Aci Performance category. So there are a number of ACI measures that really rely on health information exchange. So there's a number of places where HIOs can actually support ECs, and a lot of this are things that they're already doing, like supporting transitions of care, having patient portal options so that credit gets accrued to everyone, and then of course public health and clinical data registry reporting, which is an area that HIOs have been really strong in the past. If you think about the health information exchange requirements, they are actually increased in stage 3, so it went from transitions of care to both transitions of care and receiving data and incorporating it either through query or through direct. So those things have actually upped in stage 3, making HIOs more relevant to meeting some of the MIPS requirements. And as Corey pointed out, you're incentivized to achieve high scores. So just meeting your threshold of 10% for transitions of care is no longer going to be good enough. Unless everyone hits 10%, which could happen, you really need to start performing high because that's going to affect your overall score for the whole category. And again, there's a competition that's been put in place with the methodology CMS has used to try and push providers to get higher and higher scores so that they can perform better when they're compared against everyone else. And so we think HIOs can definitely help, particularly with groups who don't have the technical capabilities to do the exchange. They can really help with exchanging, sending and receiving those care summaries. And then there's the clinical practice improvement activities. I was very pleasantly surprised to see that a number of the CPIAs actually relate to engaging with health information exchange. I know for the most part these are medium scoring weights, not high. We certainly submitted comments to CMS that these should be high because health information exchange is important. So there's a number of things that HIOs can do in these categories, like providing care coordination, like care planning things. I'm just going to go through these because you'll see these in the slide deck once we share it. If you become a QCDR, there are CPIAs related to being a QCDR, which technically anyone can become one. You just have to go through a very rigorous process. And then longitudinal care management, so doing things like event notifications and closing referral loops, all of that can count towards that category. And then a lot of PDMP work. Obviously for the administration, the opioid epidemic is something that they've identified as an issue they want to address and made really important. And so PDMPs are becoming really a very high focus of the administration in particular. And so there's a number of CPIAs where if you as an HIO are providing that PDMP, it's a way to engage providers again. And then with the APM HI requirements, CMS in the rule did seek some comments on the use of HIE by APM, some things around governance, which wasn't too surprising, some things around making it a requirement that using health information exchange is either part of the definition of CERT or part of being an advanced APM. And so they had a couple questions. So clearly CMS is thinking through how HIOs can support APMs, which is, I think, really positive news. 2 more slides and then we'll do questions. Based off of our Health IT framework, there are some near-term opportunities for HIOs to support APMs, and really these items are pulled from the current state. So this is where we are today. These are the needs that APMs have right now in order to be able to participate in them successfully. And so things like a provider directory that can help them link together providers who aren't necessarily all in their health system because they're contracting across organizations. Helping with linking clinical and claims data. So if you're thinking of it being a QCDR or a qualified entity, being able to link together that data is really powerful for these APMs. Event notifications, of course, I think a lot of HIOs are doing this now, and I think that's pivotal for care coordination, sharing clinical data amongst your APM participants, and provider-based ECQM. So if you have the clinical and claims data and you have a provider directory, HIOs are really well positioned to do more holistic ECQMs for these APMs. And then long-term opportunities, I just pulled out a couple of the items from the framework in the ideal state that we think HIOs are well positioned, particularly if they jump on the short-term opportunities and move forward. There's a number of different things that the HIOs can support, including aggregating together the clinical and claims data and providing that back to the APMs, helping close the referral loops, things like event notifications or care gap notifications or patient-generated health data notifications. All those things are things that HIOs are really well suited to support. And then data submission methods, I think one thing to just keep in mind if you're an HIO and you're trying to think through all of this, QCDRs are one path to be able to support data submission methods to CMS under the program. I will say it is a rigorous qualification process with a lot of auditing on the back end, so you should be very aware if you go into that process that it's not a one-week process, it's a month or a couple month-long process. And then there are some requirements within the regulation. If you want to be a QCDR for 2017, you have to already be in existence before January 1. You have to have a certain number of practices already, in contract with you to use your services. A couple of key things like that you should keep in mind. And then the second is a health IT vendor, and this is really tightly linked with certification. It's not clear whether the health IT vendors and how CMS said this in the rule, if they would have to be certified or if the cert is certified and the health IT vendor can be a totally separate entity. We are expecting them to clarify that in the final rule. I think a number of health IT companies submitted comments on that, trying to get them to clarify. I suspect that it will be certification required. So if you're thinking of submitting quality measures, you probably will have to be certified for 2015 to what are the C1, C2, and C3 criteria, which are all calculating quality measures, things like that. And then a couple other considerations. Do you have to get any of your infrastructure certified? So there are a lot of times in the rule where CMS talks about using certified technology, and so you might need to consider whether anything that you're doing, whether it's for public health reporting or anything else, needs to get certified. As Corey, I think, alluded to, and I've alluded to, the majority of practices with less than 24 providers, CMS is anticipating we'll see a negative payment adjustment. If you haven't heard it yet, MIPS has to be budget neutral, which means the amount of money you're giving out as a positive incentive, you have to take that much out of a negative incentive. And based on what CMS included in the rule, it seems like most of that negative payment adjustment will come from those small providers. And it's because they just don't have the health IT capabilities or the administrative organizational capabilities to be able to understand what is currently a 960-page rule, what will likely be probably 1,500 pages in its final state, really understand that and figure out what it means for them. And so, there's a lot of practices who are going to need assistance with doing this program if they want to even end up neutral. So there is a potential opportunity to offer small practices some of the health IT capabilities that they might not be able to afford. They might not be able to afford a product that can accurately calculate their quality measures, and their EHR vendors might not be doing that accurately for them, and it really is going to matter that they do that right. And so they might be in the market for some low-cost options for doing things like that HIOs should really just keep in mind. And I think we are on to questions, and I'm going to expand this. So if you have, I know we are close on time. We're happy to stay on for longer. If you have any questions, you can just submit them via the chat. I believe we will see them, and we will answer them. To answer the question that always comes up first, yes, we will share the slides, and we will share a recording on our website. I know that's #1 question on every single webinar. But if you have others, we'll just mute our line and wait to see if anything comes in. We're happy to do our best to answer them. All right, couple questions rolling into chat. So is there a simple fact that you can recommend for us to share or put on our website for EPs? So one thing, I know this is really hard. We have to start switching up terminology. So eligible clinicians in this program, and that becomes important if you're also supporting Medicaid providers, because they are still EPs and they have different requirements, unfortunately. I don't know that there's a simple fact. There are certainly a number of very good summaries that are geared towards clinicians in particular. The AAFP, the American Academy of Family Practitioners, they did a really comprehensive summary that I think was pretty easy to digest. If you are interested in any of those summaries that are geared towards eligible clinicians, just drop us a note and we can certainly send you links to some of the summaries we've seen that were good. A second question, what's the most important direct short-term need you see in the health IT space to support this properly? So if you're talking on the MIPS side, I think the most important is that you really need to figure out your strategy for, frankly, upgrading your certified technology to the 2015 edition. So by January 1, 2018, for the MIPS program, you have to be using 2015 certified technology. This gets confusing with naming of how vendors do this, but it's the 2015 edition from ONC. So really, I think for the MIPS side, from a health IT perspective, they really have to be thinking through two things. One, when are they going to upgrade and how will that impact their performance period? And two, how are they going to get accurate ECQMs? That is a significant problem right now in our space. For a number of years, CMS has just said, it's okay if they're not accurate, just submit them. And now that accuracy is really important. So I think ECQMs, even on the APM side, since your payment is tied to them, are probably the most near-term need that folks have to be able to do those accurately and comprehensively. On the APM side, there's a whole host of things you need to be able to do. It would be hard to choose what the most important is. So.
Yeah, I think just one thing I would add, for HIOs and other organizations of that ilk, I think one of the important things to do right now is have conversations with your providers and see where they need help and where you can support them, because positioning yourself, you're going to need to start working on the infrastructure you need now to support ECs for 2017. So just an important consideration, listen to your providers, hear what they're asking for and where their needs are in your community, because it's going to vary across the country.
Yep. We have another question come in. Do you see Medicaid adopting a similar program on a state-by-state basis in the future? So a couple things with that, and that's actually a very good question. In the inpatient proposed rule that CMS just released, where they modified the hospital Medicare EHR incentive program requirements and lowered every single threshold, they specifically stated that they weren't yet proposing for Medicaid to modify anything because they were concerned about the ability of states to modify their state-level repository systems in time for attestation, and they were concerned about that burden. We certainly are going to be submitting comments around that, as I think lots of folks are. I do think Medicaid is going to move the same direction on the MIPS side and align. I think they're going to try to align the meaningful use. I think it's going to be really confusing for providers if we don't, so we're certainly hopeful they will. On the APM side, I think we're already seeing that. A number of states have programs like DSRIP. They're participating in the state innovation models. They're doing patient-centered medical homes for Medicaid providers. So I think we're already seeing states start to move that way, particularly the really forward-thinking ones. And so I anticipate that Medicaid programs will continue to move that direction because really those value-based payment models are where we're trying to move to as a country overall. And so I think Medicaid is wise to that and is trying to go that direction. Let me see. And I don't see any other. I will do a last call for questions. Oh, here we go. Will HHS publicly publish scores? Excellent question. Yes, they will. So the provider, oh, I'm blanking on the name of it. The
Physician Compare.
Thank you. Physician Compare site will publish certainly the quality measure scores. CMS was a little bit wishy-washy on the advancing care information category, though they will definitely tell folks if they achieved a score in that category. It's not clear if it'll just be the composite score for the category, if it'll be the individual measures, likely the composite score to start with. But the quality measure scores will be there for each quality measure the provider submitted. Yeah, good question. Any other questions? All right, great. So our contact information is up on the screen, and certainly if you have additional questions, you're welcome to reach out to us. We will work to put the recording and the slides up on our website before the end of the week, so they should be up there definitely by Monday. And we'll probably also send a link out to everyone who registered for the event once they're available, so you guys can have easy access to them. But we appreciate you joining us today. This is a complex topic, which it takes a little digging into, so as you digest things in these slides and have further questions, we're always happy to answer those if you reach out to us either on Twitter or Facebook or our direct email addresses. Thanks for attending today. We appreciate it.
Yeah.
Appreciate it. Other questions,